Well, ladies and gentlemen, it's my great pleasure to introduce our keynote speaker and Lifetime Achievement Award recipient and share a brief bio sketch about our friend and colleague, Dr. Johan Francois Coetzee, professor of anesthesiology at the University of Stellenbosch. The son of a physician, Dr. Coetzee spent his formative years in the country surrounding Africa's southern Cape. Johan was born in Zambia and raised in Rhodesia. He was educated in South Africa. To the untrained North American ear, the beautifully enunciated consonants of Dr. Coetzee's accent sound characteristically South African. But in fact, to the discriminating trained ear of people from that region, I've since learned that it's a Rhodesian accent. And Jeff has some funny stories to tell about that. Some of you may know Johan as Jeff, and there's a unique story about that as well. His formal education, both in college and postgraduate studies, including a PhD in work in computer science as well as medicine, was centered in the heart of the Dutch Afrikaner region of South Africa and at their premier institution of higher learning, University of Stellenbosch. And in his residency group, because this is the heart of Dutch Afrikaner country, there were numerous residents named Johan. And so Jeff, because of his middle initial F, came to be known as Jeff instead of just Johan. So many of us know over the years have known Johan as Jeff. Like so many from the far-flung reaches of the Commonwealth, Jeff's life has been animated by adventure. He cycles the African bush, he harvests crayfish, lobster-like creatures from the shoals of the seafloor near his house, and he free dives in the very deep waters off the coast of South Africa and other parts of the world, hunting animals that are many times his size without the benefit of oxygen tanks. Jeff has many virtues. I think a single word that describes Dr. Coetzee is indomitable. Jeff and the Coetzee family, his wife Cora and sons Francois and Marcus, have faced some very significant adversity in their lives, and they've done that with toughness and grace. The Coetzee family is a family that knows how to ride out serious storms and keep sailing toward the destination. There's a very simple reason that Dr. Coetzee was nominated as a recipient of the Lifetime Achievement Award. And that's because on the continent of Africa and throughout the world, really, anesthesia, clinical pharmacology, and intravenous anesthesia is inextricably connected with his name and his contributions. So as former president of ISAP, under the direction of the officers and board of directors, I'm very pleased and very honored to present our Lifetime Achievement Award recipient, Dr. Johan Francois Coetzee.
I just want to get my presentation up. Well, thank you, Talmage, for those kind words. The board members of ISAP and all you members of the society for this, for me personally, a great honor. It also came as a complete surprise, and I stand somewhat awed in front of you because so many of you sitting here and members of this society have acted as mentors to me in my career and in my journey of discovery, as Steve Schaefer mentioned just now. Many of you, unknowingly so, have acted as guides on my journey of discovery and in my thought processes and in my motivations in what I should do in my research and my teaching and in my interactions with my colleagues and friends. So this, some bit of a cliche, certainly applies to me in my case. Now, when Ken sent me an email inviting me to be here, he gave me some instructions. He said I should say something about myself and my career. Now, this being the last lecture of the day, I don't want to bore you with a whole lot of dull details, but perhaps I could show you just a few glimpses into what I'm so thankful for. I think I had a very unusual and exciting life. So when I was born in 1941, during the Second World War, Africa was dominated to a great extent as by the British, being part of the British Empire. And what you see there marked in red and in pink was the British Empire at that time, and the dates you see there are the dates at which these countries achieved their independence, and the majority of them in the early 1960s. I was born in a copper mining town by the name of Nkana, and the country was ruled directly from Whitehall by a governor who represented the king. And you couldn't own property, you leased property from the crown. And my father was a physician, he was a specialist in tropical medicine, and he was superintendent of this little hospital where I was born. And it's quite interesting to see the attire of the nurses, all with their very spotlessly white starched veils. No nurse would ever be seen without her veil. She would be regarded as being almost naked. I was born in that little hospital, and the obstetric unit was full, so my mother had to go in labor and deliver me on my father's examination couch. Now, at the time, Northern Rhodesia was known as the Black North, not because it was darkest Africa, but because of the high incidence of blackwater fever, which results from massive hemolysis from malaria. And my father spent a great deal of his time and his energy in eliminating malaria from the copper mining towns. And for that, in 1958, he was granted an MBE by the Queen. And this is an interesting photograph because here you see the governor in his finery with ostrich plumes and sword, etc., awarding my father the MBE. And what's interesting is the inscription on the medallion saying, "For God and the Empire," which I think attitudes have somewhat changed today. My childhood was very outdoorsy. It was one of adventure, riding with my sister in the bush and my parents, my mother with our pet cheetah, my first fish, hunting with my father, and then later as a teenager, having the privilege of wandering around and hunting in the bush myself. I even learned to play polo, and that's myself and my father when we played against the touring Uruguayan side, who beat us roundly in spite of using the inferior horses that we lent them. Now, primary school was okay in Nkana. You see it up in red over there. But my parents decided that high school, I need to be sent away, which was the fashion at the time. And actually, they couldn't have sent me further. I had to travel by train from Nkana through 4 countries, 2,400 miles, and it took a journey that took 5 days. So this is where I was educated, and the school where I was situated somewhere over there. And this is Tygerberg Hospital, taken some years ago. These open spaces have now been occupied by student residences. This is the medical school, and this is a 2,000-bedded hospital. And I had the privilege of giving the first anesthetic in that hospital. It was a cesarean section when I was a young consultant. And you see Table Mountain in the background, which is familiar to most of you. And looking from the opposite aspect, you'll see Stellenbosch. Stellenbosch is somewhere off the screen here, it's nestled among the mountains, which is a famous wine-growing area. And my most memorable ISAP experience was the meeting that we had there, the satellite meeting at the Spear Estate, which was, I think, a remarkable occasion, because all the speakers that I invited and asked to deliver talks, they all readily agreed, and we had a great time. And I do hope that this will be a tradition that ISAP will continue. I think it's very important in order to expose ourselves as a really international society and to get membership from countries from all over the world. Ken said I should say something about my career. The first anesthetic that I delivered was as a medical student, and that was Trilene. And if you look up Trilene today in Wikipedia, I'll quote, "A heavy, colorless, highly toxic liquid used as a solvent to clean electronic components and for dry cleaning as a fumigant, causes cancer and liver and lung damage." That was 48 years ago. Now, a sobering thought, what's going to happen to the marvelous drugs that we have today? Now, if I look back in my career, you'll see marked in yellow there are drugs that I used and which I saw disappear from the scene. And I'm sure that there are many members of your departments who've never used halothane, although it's still used in my country. And also, what's intriguing to me is the resurgence of interest in these drugs over here. And here's another drug, if we think, go back on our journal of discovery, and that is this date rape drug. I actually used this drug as an induction agent. It's soluble in water, it doesn't sting, it has wonderful, stable cardiovascular properties, and we used it quite often there was a limited supply. One of our consultants used to import this directly from France. Gamma, it's a sodium salt of gamma hydroxybutyric acid, which is very closely structured, as you can see, to GABA. So perhaps that's a thought that for future development. The articles that probably most influenced me were these ones, and I think this has changed our thinking about anesthesia. Before these articles appeared, we're quantifying the synergistic effects between opioids and hypnotics. We had an instinctive feel about this, but these articles quantified the relationship and has motivated most of us, I think, in going towards target-controlled anesthesia. My other passion is spearfishing. And here's just a brief look at some of the trophies that I have brought to shore during my career. Now, I got a second email from the administration of ISAP informing me that the talk I must give must have CME points. So unfortunately, I must now go on to a more serious subject. Now, the most publicized case of pharmacokinetic simulations being used in a court of law was Steve Schaefer during the trial of Conrad Murray for the murder of Michael Jackson. And he demonstrated that the doses of propofol that Dr. Murray claimed that he gave could not possibly have resulted in the post-mortem concentrations that they measured. As a matter of fact, they could have only been achieved by infusion, and even after the patient had stopped breathing, that the infusion continued. He also performed a unblinded, uncontrolled clinical trial in which he enrolled only one subject, and that was himself, by drinking a large quantity of propofol and demonstrating that Michael Jackson certainly could not have poisoned himself. Now, the first published instance in which pharmacokinetic simulations were used at an inquest was by Johan Lotz, who was an expert witness at an inquest of a 26-year-old girl weighing 51 kilograms who underwent knee surgery. And in the PACU, she complained of pain, and they tried to control her pain with repeated injections intravenously of morphine. So she received 35 milligrams in 1 hour and 45 minutes, and there's a simulation of the blood concentrations. And is also then followed by a simulation of the expected effect site concentrations, and that was the concentration at the time of the cardiorespiratory arrest. Now, he compared these concentrations with a study that he did of respiratory depression in volunteers. And he gave two doses, a fast infusion, 20 milligrams of morphine, followed by a slow infusion, and those are the simulation of the plasma concentrations and a simulation of the effect site concentrations. And the stage at which these volunteers were seen to have severe respiratory depression coincided with those of the patient. But the important thing that they also noted here, and which I'd like to emphasize here, and that is there's a huge discrepancy usually between the plasma concentrations of morphine and the effect site concentrations. And the reason for that, of course, is that morphine is water-soluble. It takes a long time to get out of the circulation and into the brain. And once having entered the brain, it takes a long time to exit the brain once again. So as you can see here, when the concentrations of morphine have already decreased to very low, the morphine in the effect site is only now just reaching the maximum concentration. So comparing the two simulations for the effect site, we can see that he did his measurements in nanomoles per liter. In units that we're more used to, we can expect apnea or at least severe respiratory depression at concentrations of about 40 nanograms per milliliter. So I'm going to just relate to you a few cases in which I was directly involved. Now, this was an interesting case. It was a female, 26-year-old, who had a peritonsillar abscess, and she came for a tonsillectomy. No pre-medication. Her anesthetic was unremarkable, and soon after induction, she received 10 milligrams of morphine. In the recovery room, she was awake, stable, good airway, no bleeding, but she complained of pain, and she was given another 5 milligrams of morphine. 20 minutes later, went to the ward, and in the ward, she was found 3 hours later to be pain-free, vital stable, normal respiration. 6 hours after her first morphine dose, the fellow patient called the nurse and said, the patient is breathing funny, and now she is quiet. And she had suffered a cardiorespiratory arrest from which she could not be rescued. So I was then asked, can PKPD modeling help here? So at this point, I must digress a little and just discuss the PKPD model that I chose for this purpose. And this was based on a study by Albert Johan and his co-workers, who studied 16 opioid-naive young healthy volunteers, measuring analgesiometry and simultaneously challenging them with carbon dioxide and hypoxic challenges and measuring their respiratory responses, and at the same time measuring morphine blood concentrations. And here is a graph of the dose-response curve for morphine that they drew up. On the x-axis, we have morphine concentrations, and on the y-axis, the depression of response. The dotted line illustrates the response of morphine for pain, and the solid line, the depression of respiratory responses. And what's interesting to note here is that at concentrations at which there's very little suppression of pain responses, we already have quite marked respiratory depression. And the EC50 happens to coincide for both curves at a concentration of about 9 nanograms per milliliter. They also remarked in their publication that when the respiratory responses are decreased by 60%, in other words, down to 40% of normal, this translated to a depression of the alveolar ventilation by 40 or 50%, and an increase of the arterial PCO2 to by 10 or 15 millimeters of mercury, which are concentrations of carbon dioxide concentrations at which carbon dioxide narcosis begins to take effect. So we can perhaps define, according to this model, an area which we should avoid, a threshold which we should avoid, and perhaps a therapeutic window below which pain suppression is insufficient, but within which we have acceptable respiratory depression. And it's interesting to note that within this therapeutic window, the steepness of the dose-response curve is greater for pain than for respiratory depression, which is somewhat advantageous. So to summarizing these three publications that I've mentioned, we can define hypopnea as a depression of respiratory responses in opioid-naive healthy young adults by 60% at a concentration of about 14 nanograms per milliliter. And when these responses are depressed by 80%, this occurs at a concentration of 40 nanograms per milliliter. So let's go back to our patient who died after the tonsillectomy. There are the plasma and the effect site concentrations, and the question is, was this respiratory suppression sufficient enough to cause respiratory arrest? And we can redraw that curve looking only at the effect site concentrations, putting the effect site, the therapeutic window, and the danger zone into the graph. And there are the two doses that the patient received and the effect site concentrations. And we can also draw the pharmacodynamic response. And we see that, for the average opioid-naive young adult, the concentrations do go high, and they just reach this theoretic threshold for severe respiratory depression. And of course, we know that there's this tremendous individual variability between patients in their pharmacokinetics and pharmacodynamics. So there's a broad window of variation. All we know about the patient is her weight and gender. There were no other drugs on board. There was no comorbidity. So looking at her weight, she did receive a large dose. And it's also well known that women do happen to be more sensitive to opioids with regards to both analgesia and respiratory depression. But going back to the model of Johan and looking at the confidence intervals, and we take these extremes of the confidence intervals for both clearance and the EC50 and redraw our simulation, we find that in such a patient, indeed, you could get severe respiratory depression. And the threshold at which they stop breathing, we don't know, but it can vary. However, so much for central respiratory depression. And as defined by McIntyre, he induced the term opioid-induced ventilatory impairment, which is mainly determined by three interrelated factors. Not only depression of respiratory drive, but the presence or absence of pain, and also the mere fact that someone falls asleep can increase respiratory depression. And also there's a very important factor that comes to play here, and that is an airway obstruction. The nurses made a significant note here, and that was that the patient was asleep and snoring. And to summarize the effect of a patient falling asleep and of sedation, we know that opioids lead to impaired ventilation through central depression. And the presence of pain antagonizes this effect. But what we don't all realize clinically is that once you relieve pain, that removes that antagonism. Furthermore, the mere fact that a patient falls asleep has been shown to potentiate the respiratory depression and the impaired ventilation. Now, the presence of airway obstruction, as we all know, is just as important. And the nurses made a note that the patient was asleep and snoring and lying flat on her back. And the genioglossus muscle, as we know, is an important airway dilator, being inserted onto the back of the mandible and into the hyoid bone and the tongue. It has the function of pulling the tongue forward. But morphine has a direct effect on the genioglossus muscle, as shown by this experiment in rats, where they did a fentanyl microdialysis into the hypoglossal motor nucleus and demonstrated that in these rats, the genioglossus activity was reduced and could be reversed by naloxone. And a recent publication in anesthesiology this year demonstrated in volunteers a dysfunction of the pharyngeal muscles as a direct result of 0.1 milligrams per kilogram of morphine. As you can see here, there was dysfunction with regards oral coordination, laryngeal protection, frequency of swallowing, etc. So the judgment at the inquest eventually was that the patient probably died due to morphine-induced ventilatory impairment and due to central depression combined with airway obstruction, and that nobody was to blame. The next case was a patient who underwent shoulder surgery, a young male, also unremarkable anesthetic, but in addition he received an interscalene block with ropivacaine, and the surgery took 1.5 hours in the sitting position. Post-operative, the total amount of analgesics he received, were, besides the brachial plexus block, was an injection of cyclomorph, which is a combination preparation of 15 milligrams of morphine and cyclizine, 50 milligrams in one ampule. He also received parecoxib and paracetamol. And in the recovery room, a PCA was set up for him, consisting again of cyclomorph, which contained 50 milligrams of morphine and 50 milliliters. And this was set up to run a background infusion of 1 milligram per hour of morphine and a demand bolus of 2 milligrams with a lockout interval of 6 minutes. In the ward, he coughed up a little blood. He was noted to be sleepy at about 4 o'clock in the afternoon, but at 7:30, he was still awake and responsive, coughed up a little blood again. At 8 o'clock, he was noted to be asleep and perspiring. They measured his temperature and it was normal. At 10 o'clock, he was unrousable. At 2 o'clock in the morning, he was asleep with a systolic pressure of 60. Still no one did anything. At 6 o'clock in the morning, he was unrousable with a Glasgow coma scale of 3. He was cyanotic with a low BP and pinpoint pupils. He was transferred to the ICU, where he was intubated, ventilated, and resuscitated, and there they discovered that the PCA syringe was empty. The patient had permanent brain damage. Legal action was instituted, and the differential diagnosis that was offered was, first of all, of course, a morphine overdose, but also perhaps cerebral hypoperfusion, because the patient was operated on in the sitting position. And the fact that he had hemoptysis was suggested that he may have suffered from a pulmonary embolus. But of course, the evidence was scant, and there was a huge amount of opiates present in the patient's urine, so the primary diagnosis was morphine overdose. The question was, how could this have occurred? And root cause analysis for adverse effects in PCA come up with two most common causes, and that's a programming error and self-administration. So as an illustration, one could suppose that the concentration of the syringe was probably 1 milligram per milliliter, but that the person who set up the pump could have by accident put in a concentration of 0.1 milligrams per milliliter. On the other hand, if the intended background infusion was going to be 1 milligram per hour, they could have keyed in 10 milligrams per hour. Either way, the intended 1 milliliter per hour could have ended up with an infusion rate of 10 milliliters per hour. And here's a simulation of the concentrations that happened. And you can see that within a very short time, the concentrations entered the therapeutic window, went right through the therapeutic window, and these are the events that were recorded clinically, and probably that sweating episode was probably due to hypercapnia, and that was the time that he was unrousable, was at the peak concentrations in green, the effect site, and that's when the blood pressure fell and when the pump was discovered to be empty. On the other hand, it's possible that the patient could have self-administrated, and he could have only done this while he was awake. So assuming that the background infusion was correct, he would have had to give the rest to himself by means of 17 2-milligram doses, which, for the sake of the simulation, were spaced 23 minutes apart. And you get a very similar type of curve taking place in the effect site. So the conclusions were that the patient's analgesia was excessive, with an interscalene block, plus morphine intraoperatively, plus the other non-steroidal analgesics, and then post-operatively the PCA morphine. Undoubtedly, the cyclizine, 166 milligrams given during that time, contribute to the sedation, the hypertension, and depression of respiration. It's likely that there was a programming error, but of course, the elephant in the room was that the nursing was very poor, and they missed repeated opportunities to rescue the patient, and the case was settled for a large sum. Cyclomorph again brain damage, and I illustrate this case not to so much illustrate the simulation, but to illustrate a problem that I had here. Now, this patient, after induction, received repeated doses of cyclomorphine. Here is the dose intraoperatively. This was postoperatively 5 milligrams intravenously plus 10 milligrams intramuscularly, and 4 hours later, another 15 milligrams of morphine. Remember, with cyclazine. An hour after that, the patient was noted to be asleep and breathing noisily, and she went into respiratory arrest and also suffered brain damage. Now, the problem here with the simulation was to simulate the intramuscular injections. Easy to simulate intravenous injections, but how do you simulate extravascular absorption? So it's quite simple, really. If this is the formula for extravascular absorption, where A is the amount absorbed, F is the bioavailability, D is the dose, and K is the rate constant. Now, the publication by Don Stansky on intramuscular morphine, he demonstrated that it's fully absorbed with an F of 1, therefore, and that the half time for absorption was 7.7 minutes. So one can then calculate the rate constant, which is simply the log of 2 divided by the half time. So I could then, for the simulation purposes, then draw up a table of constant rate infusions to approximate that exponential absorption of morphine. You can see over here that for the first 7.5 minutes, a rate of 58 milligrams per hour to deliver half of the given dose, and then the half of the remaining is given over the next half time, etc. And comparing the curve of the equation with the approximation led to an error of only 0.7%. So here is the simulation again of the concentrations in the effect site, and of course, huge concentrations achieved to the point of apnea. The last case is the most interesting case, so I hope not all of you are asleep at this time. This was a 26-year-old female with a BMI of 30 who was a multi-drug addict. She was addicted to heroin, diazepam, taking 30 milligrams a day, cannabis, methamphetamine, and cocaine. She was admitted to an institute for initiation of methadone maintenance therapy. She was also taking an antidepressant, and when she was examined clinically by the doctor, he noted that she was agitated and appeared to be in withdrawal. Her urine contained traces of benzodiazepines, cocaine, opiate, as well as cannabis. And she had a normal blood glucose. On the second day, she was given her antidepressant in the morning, and methadone was started in the evening with 20 milligrams orally with diazepam 30 milligrams. The next day, she was given 3 similar doses of methadone 20 milligrams and diazepam 20 milligrams. At 9 o'clock that evening, she retired to bed. She was also given 2 doses of aloe vera, which is used in that institute as a laxative. During the early hours of the morning, her roommate noted that she was snoring heavily, and the nurses noted later that she was unrousable. A little later, they found that she had suffered a cardiorespiratory arrest. They attempted CPR, they drew some blood, and resuscitation was unsuccessful. So at post-mortem examination, it was found that she had aspirated her gastric contents, and there were signs of bronchopneumonia. Her liver revealed fatty degeneration, and the blood sample that they took showed raised enzymes with a low albumin, and there was no brain pathology identified. The toxicology were these levels here, somewhat higher in the stomach than in the femoral blood. I'll come back to that later. So, at first glance, this appears to be a case of straightforward respiratory depression by a combination of methadone and diazepam. And the arguments for this are, first of all, most methadone deaths described in the literature occur during start of therapy. They occur at night and often associated with bronchopneumonia. And the post-mortem concentrations of methadone vary from case report to case report and study to study. But concentrations as low as 60 nanograms per milliliter have been recorded, and hers was round about 90. The advice given by the World Health Organization, the South African Addiction Medicine Society, and various other authors concerning methadone therapy also advise one should start slow and go slow because you do not know how opioid tolerant your patient is. So the general advice is that the dose for the first 24 hours should be less than 30 milligrams, but she received 60 milligrams. It's also advised that that benzodiazepines are often implicated in these deaths, and they should be avoided. She received 60 milligrams in 24 hours. So for the purposes of the simulation, I chose this model by Wolf because it conveniently contained a group of opioid users whose absorption half-time is somewhat prolonged because we know that opioids do affect bowel function. And again, simulating extravascular consumption, I put the slide over here because the pharmacokinetic model was developed from volunteers ingesting 10 milligrams of methadone, and you can see that this graph exactly coincides with the model that they developed, which is the solid line over here. So that gave me confidence in my model. So here's the simulation of the expected plasma concentrations, increasing progressively with each dose of methadone. And there is the post-mortem concentration, which agrees, the concentration measured in femoral blood agrees quite conveniently here with the post-mortem concentration. For the diazepam modeling, I used this model by Eatman, and simulating again the extravascular absorption, a similar pattern for diazepam. However, what is rather unexpected is that these concentrations are much, much higher, the expected concentrations, than the post-mortem measured concentrations. So, are we still convinced that this is unquestionably a methadone-induced death? In the nursing reports, it was reported that if the patient walked into the pharmacy each time to come and receive her methadone dose, and each time she was examined, and they noted that she was alert, she was orientated with normal gait and speech, and her pupils were normal. So it's quite likely that this was an opioid-tolerant patient. And if we look at more closely at the post-mortem concentrations, we see that the stomach contents much higher than the blood content. So the concentrations were actually increasing at the time that the patient's circulation was inadequate, so inadequate that she was no longer absorbing drug. And, sorry, how did that happen? Goodness. Oh, wait a minute, sorry. No. Okay, sorry about that. So to get back to the point, at the time that her circulation failed, the last dose had not been completely absorbed. And so probably the graph looked more like this, that the concentrations were actually still increasing at the time that her circulation collapsed. And secondly, the diazepam concentrations were just at the lowest limit of quantification. So it's quite likely that the patient did not ingest that last dose of diazepam. And so this throws a little doubt now on respiratory depression being the cause of death. And if one looks at the histology, the pathologist specifically stated there's no microscopic pathological or structural abnormality identified. Specifically, no ischemic hypoxic change, edema, or inflammatory changes are observed. This is not compatible with a diagnosis of respiratory arrest. And if one looks at the notes made during the resuscitation, I'll make it clearer for you here. At the time of resuscitation, this patient was severely hypoglycemic, and it required repeated doses of glucose to get the blood glucose up again. So, looking into the literature, it's well described that high doses of methadone can cause hypoglycemia. And furthermore, in certain parts of the world, aloe vera is used, particularly in India. Aloe vera is used as a treatment for diabetes, probably by release of insulin. So in this case, the probable cause of death, I believe, was probably methadone, large doses causing hypoglycemia, aggravated by the aloe vera, and also by the fact that this patient had a compromised liver with fatty degeneration and low albumin and low glycogen stores, that she went into a hypoglycemic coma and aspirated and eventually developed a cardiac arrest. So the learning points in this talk are, first of all, PKPD simulations can help, but you've got to keep an open mind. And you need to interpret your simulations in the light of clinical events. You can simulate extravascular absorption given their half-time, and there's no relationship between morphine plasma concentrations and morphine effects. This is something you need to convince forensic pathologists about. We must realize that opioids predispose to airway obstruction because of the direct effect on the pharyngeal muscles. Also, keep in mind that sleep and sedation and pain relief by itself potentiates respiratory depression. And that lastly, certainly in our country, we have a problem with our nurses being able to recognize respiratory depression. And for that purpose, we in South Africa have recently formed the South African Perioperative Research Group. And I'm happy to report that at the University of Cape Town, they've now recently appointed a professor in perioperative care. Thank you. Of course, it's impossible to say, it's impossible to tell, but as some sort of a, what shall I say, a milestone, as some sort of a measure, one can, bearing in mind that there is variability as I try to illustrate in my one slide, one can use this, in spite of that, one can still, I believe, use this as a tool, especially when you're trying to get the concept across to a magistrate or a judge.
Oh, no, not you.
Johan, that was terrific. Thank you. How, in presenting sort of the complex pharmacokinetic concepts, how receptive was the lay listener, either the judge or the jury, to relatively, I mean, to us straightforward, but to them rather foreign concepts?
If you take time to explain the graphs, I think that helps a lot. Yeah, especially if you draw a line saying this is a threshold for the average patient, which you should not go across.
I think no more questions? No. Thank you very much.
And thank you once again for inviting me here.
I think we'll get you a plaque for the Lifetime Achievement Award. I think this concludes our program. Thank you very much for attending. I think it was a great meeting, and we have a reception outside. I think at the terrace. See you there.